Improving Depression Screening in Patients with Atopic Dermatitis by Bryn Marsh. Atopic dermatitis, or AD, is a common chronic skin disease that affects up to 25% of children and 8% of adults. It causes the most significant disease burden of all skin conditions. When compared to the general population, AD patients have been shown to experience more significant psychological distress and lower health-related quality of life. People living with AD experience severe, constant itching, visible, embarrassing skin lesions, and insomnia. All of this leads to psychological distress, low self-esteem, and negatively impacts work and personal relationships. Anxiety, depression, and suicidal ideation are common secondary comorbidities, even in those with clinically mild or moderate disease. Despite this well-established association, dermatology providers do not routinely screen AD patients for these comorbidities. This may be due to a lack of time, lack of guidelines, or the perception that psychiatric disorders are not the dermatologist's responsibility. A simple screening tool such as the Patient Health Questionnaire 2, or PHQ-2, can help recognize patients suffering from psychological distress secondary to atopic dermatitis. This tool allows dermatology providers to identify AD patients who are suffering from depression and refer them for appropriate evaluation and treatment by a mental health professional. One study analyzed over 9,000 atopic dermatitis office visits and found that only 2% of the patients were screened for depression. Currently, no depression screening in AD patients takes place at our office. This project will promote the consistent use of a depression screening tool by dermatology providers for patients with AD in order to make appropriate referrals for mental health support when needed. The root cause analysis of this quality improvement issue using a fishbone diagram initially helped to think through all possible variables contributing to the problem. Meaningful improvements in healthcare can be made with this tool by facilitating a comprehensive understanding of a problem, uncovering root causes, and determining the most effective areas to focus improvement initiatives. Once the process and problem are better understood, the model for improvement will be used to guide the improvement process, and the Plan, Do, Study, Act, or PDSA cycle to design and measure changes. The PDSA cycle is a 4-stage repeating structured approach to testing small changes to improve the quality of systems. This cycle begins with a plan to test a change, followed by a small-scale experiment and data collection. The improvement team observes, analyzes, and learns from the testing, and then determines if any modifications need to be made to initiate a new cycle. This helps to determine which small changes are helpful or unsuccessful, and then to make appropriate adjustments towards sustained delivery of this desired change. The simplicity of this tool allows for its implementation regardless of practice size or resources, and can be utilized for complex or simple issues. Successive cycles will build upon one another, continually bolstering knowledge and becoming more and more complex as new information is attained. The flexibility of the PDSA cycle facilitates new learning through repetitive change evaluation, ensuring continual improvement. It will provide an efficient avenue to meet quality improvement goals by determining what has worked well, and will save time by revealing problems. Both successful and unsuccessful changes will provide valuable information. Many small changes will need to be tested in this project to determine the most seamless route to adopt regular depression screening for AD patients, and the PDSA process is perfectly suited to do this in an organized fashion. A PDSA cycle will be performed quarterly. The planning stage will solidify the objective and target goal, assess staff needs, create an implementation approach, identify team members and stakeholders, and create a communication strategy. The change will be carried out over 1 month's time. Data collection will occur by carefully documenting observations, reviewing chart notes, and holding weekly staff meetings. The team will perform quarterly data analysis to assess the process's failures and successes, The frequency of screening and AD visits will be evaluated and compared to the baseline. Observations and staff feedback will also be considered. Based on these results, the team will learn which changes work in this setting and eliminate those that do not. The objective of the next PDSA cycle will be fine-tuned by building on the strengths and addressing the weaknesses of the last PDSA cycle. A successful communication plan will also be developed to create awareness about this issue and instill the perceived advantage of this change so that patients needing mental health support are more likely to be appropriately referred. A staff meeting with the entire office will be held to introduce this issue and delineate an initiation plan. A presentation will explain the link between depression and AD, the simplicity of the screening tool, the implications of screening or not screening, and how our office can help mitigate this problem. Technical knowledge and support will also be provided to those ready to adopt this change. The presentation and articles discussing this issue will be available online for anyone who wants more information. A specific protocol will be communicated for patients showing signs of depression, including having business cards of several psychiatrists in the area available to give to patients. Members of the spread team will also be available to facilitate referrals and to answer any questions that arise as this process is initiated. The first step in the implementation of this project is to educate medical providers and medical assistants at our office about the importance of depression screening in these patients in order to instill the perceived advantage of this change. And we will also discuss the ease with which this screening tool can be used in our office. Then we will prepare by identifying patients who will be seen for an AD visit in the next week, and a PHQ-2 questionnaire will be attached to their face sheet. Additional questionnaires will be available in each exam room for patients not initially scheduled for an AD visit. Then screening will occur when the medical assistant who roomed the patient asks them to fill out the questionnaire as they are waiting for their dermatology provider. The medical provider will then review each questionnaire during the visit to identify which patients are suffering from feelings of depression. Patients who have been identified as depressed will be referred to one of a list of nearby mental health professionals. For continual reassessment, the project will include a medical records review over the next year to measure performance. Staff meetings will be held monthly to discuss the project, and quarterly team meetings will take place to analyze the screening frequency and discuss any pitfalls or suggestions for improvement over the past 3 months. In summary, this project aims to promote depression screening in AD visits at our office, with at least 75% of AD visit notes in the next year containing appropriate documentation. Thank you.